I'm Dr. Fakir Avadi, and this is Evidence-Based Medicine and Clinical Practice Guidelines. In the words of David Sackett, the father of evidence-based medicine, EBM is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients, integrating individual clinical expertise with the best available external clinical evidence from systematic research. Just like physicians, pharmacists are very involved with providing care for patients, and that's why it's extremely important for pharmacists to be familiar with evidence-based medicine and to have the skills necessary to practice based on the best available evidence. In order to take EBM approach, it's necessary to be aware and understand the clinical research evidence. And of course, in the core of EBM is a care and respect for patients. And therefore, patients will certainly suffer if clinicians use model clinical reasoning and if they neglect or misunderstand research findings. So as you learn various disease states in your therapeutic classes, it is important to apply evidence-based medicine principles and understand the evidence behind all recommendations. The first learning objective is explain the 3 fundamental principles of evidence-based medicine. Let's take a look at the 3 fundamental principles of EBM. The first principle is that you, as a clinical decision maker, must be aware of the best available evidence. There are thousands of medical journals out there, and there are tons of articles that get published on a daily basis, and it only grows as time goes on. So because of the sheer volume of published primary literature, optimal clinical decision making ideally comes from systematic summaries of the evidence. And that's why clinical practice guidelines come into picture, which we will discuss shortly. The second fundamental principle of EBM is guides to confidence in estimates. Once we get the best evidence summaries, EBM next provides guidance to decide whether that evidence is trustworthy or not. In other words, can we rely on that evidence to make clinical decisions? What we mean by estimate is that, for example, if there was a clinical trial that looked at a specific drug and evaluated the effectiveness of that drug for a specific disease, the results of that study would be an estimate. Because those are essentially the findings from the patients in that particular study. And we are extrapolating the results from that study and apply it to the general population. So that's why it's referred to as an estimate. So if we are extrapolating, the question is, how confident are we that the results of that clinical trial are also true in the general population? More specifically, in the patient that you will provide care for. And a lot of times, the evidence is trustworthy. The trials are typically designed well. Unfortunately, at times, studies have limitations, which will lower our confidence in whether we can apply the results to our patients. There are some tools to assist with this. For example, there's a great framework that actually rates our confidence in estimates, and a lot of clinical practice guidelines use the GRADE framework in order to assess the quality of evidence when they make recommendations. Here's a snapshot of what the GRADE framework looks like. So you can see that the GRADE framework will actually rate the confidence in estimate in 4 categories. So there is a high confidence, there's moderate, low, and very low. And generally speaking, randomized clinical trial give us a higher confidence, so they are typically high or moderate, and then observational studies have lower confidence, so they typically start with low and very low. Now, these are general categories, so not every clinical trial is equal. So depending on the study, it could be either high or moderate. And then you have to evaluate those studies to decide how confident you are. So there are things that can actually lower our confidence. So for example, if the study has a risk of bias, if the risk is serious, it would actually demote the confidence 1 level. So if you have a clinical trial that would normally be a high confidence and then you find a serious risk of bias in it, it would be demoted to moderate. Now, if you had very serious risk of bias, it would actually demoted 2 levels. So it would go from high to low. Or if it was at moderate level, then it would go to very low. There are other things besides risk of bias. So there are things like inconsistency in the study, imprecision, and publication bias. There are also things that will increase our confidence, such as a large effect size, as well as dose response. The third fundamental principle of EBM is that evidence is never enough to drive clinical decision making. There will always be risk and benefit, and risk and benefit should always be balanced before a decision is made. For example, most drugs have adverse effects, but oftentimes the clinical benefit outweighs the risk of adverse effects. And of course, there are times when the risk outweighs the benefit. And it's important to understand the risk and benefit when we look at the evidence in order to be able to discuss that with our patients. There is the concept of shared decision making, where rather than the clinician just making the clinical decision for the patient's treatment, we can actually involve the patient as part of shared decision making to discuss the risk and benefit, and also to take into account the patient's values and preferences when balancing risk and benefit. Let's consider 2 patients. Let's say we have a patient. This patient is a woman with chronic pain from terminal cancer. She has come to terms with her condition, resolved her affairs, and she also said her goodbyes to her loved ones. And she wishes to receive only palliative care for comfort. Now, imagine that this patient develops a severe pneumonia. We have antibiotics with strong evidence that they are very safe and effective for treatment of pneumonia. However, as part of shared decision making, because we understand the values of this patient, we can actually argue that we can hold treatment for this patient. Alternatively, imagine another patient. Imagine this patient is a healthy 30-year-old mother of 2 children who develops pneumonia. No clinician would doubt the wisdom of administering antibiotic therapy to this patient. So although these patients had the same condition, pneumonia, the decision was very different for these patients because we use shared decision making. And of course, keep in mind that some patients are actually uncomfortable with shared decision making and they don't want to be a part of it. And that typically depends on the patient's socioeconomic background, education level, and other background differences. We looked at the 3 fundamental principles of evidence-based medicine. Now, let's describe the quality of evidence pyramid. People have cognitive biases, and they tend to select evidence that favors their particular views, which is not good. Philosophers have found that the pursuit of truth is best accomplished by examining the totality of evidence rather than selecting evidence that favors a particular view. This position is the core principle of EBM. Therefore, let's take a look at the quality of evidence hierarchy, which would allow us to identify higher quality evidence. The higher you go on the pyramid, the higher the quality of the evidence. And of course, the lower you go on the pyramid, the lower the quality of the evidence. At the very bottom of the pyramid, we have animal data, as well as simulation studies from computer models, and of course, expert opinions. Slightly higher quality is case reports as well as case series. These are descriptive studies that basically describe what happened in either a single patient or a series of patients. Higher than that, we have case control studies and cohort studies, which are observational studies. Now, above that, we get non-randomized controlled trials and randomized controlled trials, which are high quality and moderate quality evidence, and that's because these are experimental studies. In these studies, because we have control groups, we actually reduce the risk of bias. And of course, at the top of the pyramid, we have systematic reviews and meta-analyses, and these are considered the highest quality because they actually do critical appraisal of the literature. And this could include systematic reviews of randomized clinical trials, as well as systematic reviews of observational studies. Now, it's important to start at the top of the pyramid. So when there is information available for a particular question from the top of the study, that's often to rely on those rather than start at the bottom. So when we do have randomized clinical trials and systematic reviews and meta-analysis, we make decisions based on that rather than rely on animal data, simulation studies, and expert opinions. So these lower quality evidence are only useful in situations where the high quality either doesn't apply to your patient or in the absence of availability of these higher quality evidence. So there's still value to these lower quality evidence, but that's only until we get higher quality evidence. We discussed the 3 fundamental principles of evidence-based medicine. We described the quality of evidence pyramid. Now, let's use the PICO framework to clarify clinical questions. There are generally 2 types of clinical questions that you can ask. There are background questions and there are foreground questions. The background questions are questions that are preliminary and basic in nature, such as physiology and pathophysiology. These are broad questions that are often asked by inexperienced clinicians rather than by expert clinicians. So typically medical students and pharmacy students will be asking these questions a lot. And of course, experienced clinicians can also ask background questions. For example, when they encounter a new disease state. But inexperienced clinicians will ask more background questions. Here are some examples. Let's say you are on rotation and you see a patient with type 2 diabetes. And whether you have learned type 2 diabetes or not, you may want to ask what is type 2 diabetes, especially if you haven't learned it before, and that would be a good starting point before you get to treatment. And even if you have learned type 2 diabetes, maybe you don't remember everything about it. So it's a valid question to ask. And then foreground questions, which are typically asked by experienced clinicians, could include, for example, in patients with new onset type 2 diabetes, which clinical features or test results predict the development of diabetes complications? Or in patients with type 2 diabetes mellitus requiring drug therapy, does starting with metformin treatment yield improved diabetes control and reduce long-term complications better than other initial treatments? So now you see that these questions are not very broad and they're asking very specifically. There are 5 types of foreground questions. Pharmacists can be involved with any of these, but we will focus on therapy and harm in this class. When you ask questions about therapy, you specifically ask what medication therapy should you use in order to achieve clinical outcomes. And clinical outcomes are outcomes that are important to the patient. The most important outcome is always mortality. But it can also include things like symptom resolution to make patient comfortable, and of course cost, which is important to the patient. You can also ask questions about harm. This can include things like adverse effects to figure out a therapy that is well tolerated by the patient. There are also questions about differential diagnosis, and prognosis. Because we are focusing on therapy and harm, the questions that pertain to therapy and harm can actually follow the PICO framework. In order to clarify your question, you should break it into 4 parts. So the PICO stands for patient or population, intervention or exposure, comparator, and outcome. In a therapy question, you should define the relevant patient or population. You should identify the intervention group, which is typically the medication that's being studied. You should also define a comparator, which is typically either a placebo group or it could be another alternative therapy, typically the standard of care. And of course the outcome. We look at clinical outcome that would be important to the patient. In a question of harm, you should still define the relevant patients, but this time instead of intervention group, you will have an exposure group. So those are the patients that are exposed to the harm, and then you will have a comparator group, which would be either your control group or an alternative, and of course you will look at the outcome.
The next learning objective is given a disease state, locate current appropriate clinical practice guidelines. As I mentioned before, because we are in the era of evidence-based medicine, there is a vast amount of literature that's published and continues to get published on a daily basis, which makes it very difficult to stay abreast of this evidence. Now, clinical practice guidelines are valuable tools for clinicians, including pharmacists, because they provide a review of the available literature and they formulate recommendations based on the best available evidence. And many of these practice guidelines actually use tools like the GRADE framework to actually assess the quality of evidence. And they actually summarize the evidence too. So, when you read clinical practice guidelines, as you read the recommendation, you can actually read the evidence. They will give you, the references that they used, and they actually tell you how they assessed the quality of those studies. Now, unfortunately, many guidelines are not appropriately developed, and certain recommendations are not based on the best available evidence. And even appropriately developed practice guidelines are not mandates or a cookbook approach. So it is not to replace clinical judgments. Practice guidelines are important, to make sure that clinicians are aware of, the evidence is out there, and to make sure that it also saves them time because as I mentioned, there are tons and tons of articles that get published on a daily basis. So clinical practice guidelines are very important to make sure that the clinicians are aware of the evidence, but they're not to replace clinical judgment. So you have to, they're not a cookbook. They're not to, it's not that say that every one of your patients, must have the recommendations in the guidelines. So it is extremely important that you avoid memorizing and quoting practice guideline recommendations without critically analyzing and evaluating the evidence behind the recommendation. Because that's the part that, when you use critical thinking, then you decide whether those recommendations apply to your patient or not. And if you just memorize the recommendations, then you won't be able to understand whether those recommendations apply to your patient or not. So again, it's extremely important to make sure that you understand how to analyze and evaluate the evidence behind those recommendations, so that you know how to apply it to your patient, or if they actually apply to your patient. Now, there are a lot of organizations out there that make clinical practice guidelines. I've listed here some of the more common ones, and in class we will. So these are just organizations. So for example, American College of Cardiology. That's very broad, cardiology. So they make guidelines for, let's say, heart failure. They make guidelines for atrial fibrillation. They make guidelines for acute coronary syndrome, etc. So, American College of Cardiology is not a guideline, it's an organization, and they make multiple guidelines. The same with, let's say, American Diabetes Association. The American Diabetes Association is just an organization, but they make guidelines for diabetes, for example. Let me go down the list. So the top one, AASLD, or American Association for the Study of Liver Disease. They make guidelines for anything that has to do with the liver. So, for example, cirrhosis, ascites, things like that you haven't learned yet. But you should be aware of the organization. And as you learn disease states that are related to these organizations, you should keep track of those guidelines and understand the evidence behind those recommendations, so that when you go out and practice, you understand where those recommendations come from and what's the evidence behind it. American College of Gastroenterology makes guidelines for anything that's GI related. So, for example, if it's GERD or gastrointestinal bleeding, or anything that has to do with GI. Let's see. The ASPIN guidelines, anything that has to do with nutrition. So if you do TPNs, those are the guidelines to go to. Anything that has to do with thyroid, so hyperthyroidism or hypothyroidism, you will go to American Thyroid Association. The CDC makes guidelines for sexually transmitted infections, immunizations, for example. Department of Health and Human Services makes the guidelines for HIV is the most important one, and opportunistic infections. The gold guideline, the gold. So sometimes the organization and the guideline are called the same. So the gold guidelines are important for COPD. Once you guys learn about COPD, make sure you know where to find gold. And we'll do some activities in class. Anything that has to do with infections is IDSA. Anything with nephrology, so CKD and AKI are the two important ones in nephrology, so that you will have to go to the KDIGO guidelines. Anything to do with oncology, you would go to NCCN. Critical care, SCCM. I know these are not, this list is not comprehensive. I've just listed some of the common ones. There's also, there's a pediatrics organization. There's a psychiatric, American Psychiatric Association. So there are a lot more there's a neurology. There are a lot more organizations, but these are the most common ones. So for example, if you were doing a pediatric rotation, make sure you go to the pediatric guideline. There are a lot of guidelines there. Now you can find the guidelines on either on their websites. So if you go to American Heart Association website, you can find them. You can also find them through PubMed too. And sometimes they're not always available on PubMed. So some of them are considered gray literature. So sometimes, for example, the HIV guidelines are actually only available on DHHS website. You will not be able to find them through PubMed. So it's actually considered gray literature if it's not published in PubMed. And let's see. IDSA guidelines you can find on the IDSA website and on PubMed. The same with KDIGO. NCCN, I believe, is only on their websites. So, and to find their website, if you just Google the name of the organization, it should take you to their website. And we'll do some activities in class on how to find these. All right. Now let's take a look on PubMed. So if you go to PubMed, so let's say I wanted the guideline for endocarditis. So if I type endocarditis, it will give me a lot of results. I can actually play with the filters. So remember, you could do filters. If you customize this and scroll down to let's see, guidelines. So there's one for guidelines. So just click show, and then it will show here. So if you just filter by guideline, now I can see 188. Now, the ones that are in brackets, they're not in English. So I want to make sure that I only see the ones in English. So if you do show additional filters and add language, now I can limit it to English. Now it's down to 142. Okay, let's see what we found. Now, these are listed in chronologically. So the latest article that's published is the latest. So if you just read it, it tells you that this is the diagnosis, treatment, and long-term management of Kawasaki disease. So that's not endocarditis. Guidelines on prophylaxis for dental. So now this is talking about prophylaxis. That means preventing an infection. That's not what I'm looking for. So this doesn't say endocarditis. If you just go for the one that says endocarditis in the title, you can see there's one here for children. and this is published in Circulation. So Circulation is the official guideline, I'm sorry, the official journal for American Heart Association. And the next one, so if you wanted children, there goes the children one, and here's the one for the adults. So you see how easily I just found the guideline by using two filters. And in the top 10 results, I found the guideline for the endocarditis in children and also in adults. So the adults one is, I practice adults medicine, so it took me to the PubMed page for um, endocarditis guideline. Now the way you find it, and again, this is index for Medline, so this has also mesh terms attached to it. Let's see. Okay. And then in order to get it, you basically click on the link out to the journal. So when you click it, it will take you to the American Heart Association journal. So as I mentioned, Circulation. This is Circulation. And you can, I think I clicked on the wrong thing. Let's go back. So once it takes you to the Circulation, now sometimes articles are not free on Circulation, sometimes they are. It just depends. This one, when you click the PDF, now this happens to be free. So I just found the guideline for infective endocarditis, which this one is actually endorsed by the Infectious Diseases Society of America. So you can see this is a guideline from American Heart Association, and it's endorsed by IDSA. And then you can, go through the guidelines. So it's 52 pages. Now, let's say if this was not free, the way you could get it through the library is, if you, instead of just going to PubMed, if you go to the PubMed through the library, so if you go to library guides, go to libguides.llu.edu/pharmacy. So when you go there, it has this is a very nice guide from our librarians that's made for pharmacy students and faculty. So what you want from here is that you want to go under searching resources, because we're searching for guidelines, and then you want to search databases. So databases such as Medline databases. So if you click on databases, now it has a link to PubMed at Loma Linda University. So instead of just going to PubMed, if you just go through here, then you get access to all the journals that Loma Linda University pays for. So you don't have to pay for it. And it also gives you instructions here. I'll let you read the instructions on your own. I'm just going to click on Go to PubMed. So we're on PubMed again. It looks exactly like before, except if you look at the URL, it actually tells PubMed that you're going through Loma Linda University Library. So when you search here, so I'm just going to search endocarditis. I'm going to do the same thing. You basically get the same thing. Now you see things get highlighted because that's what Loma Linda University Library has set this up for. Let's say you apply the guideline and English filters, and you come up with the same result. So number 6 was the one for adults. So when you click it, now you can see that there's a link to the journal that we had before. Now there's a new link. There's a new link to the journal through Loma Linda University. So if you click that link and it was not available for free, then you can give it a shot through Loma Linda. So if you click it through Loma Linda, it will take you through Loma Linda's university. And if it's available, it lets you access it. So let's see. So you can access it through, it tells you here, the actual article is available. And if for some reason you couldn't find it here, you can actually request it through interlibrary loans. So if you click the link, then it opens a form, and you will fill the form. And then I'm not a librarian, so I wouldn't be able to tell you how to fill the form. if you have questions about how to request interlibrary loan, you should contact the librarians at the library, and they will let you know how to fill it out. But that's basically how you would find articles from. Now, usually major articles like this are free, so if you just click the first link, it should be available. But if it's not, then you can explore the second link and go through Loma Linda University library. The last learning objective is given a clinical question, use an appropriate clinical practice guideline to make a recommendation. Now, when it comes to American Heart Association guidelines, and you will use their recommendations, their guidelines frequently because cardiology, cardiovascular diseases are very common, so you will come across these guidelines. So this is actually how American Heart Association basically classifies their recommendation. So you can see here at the top they say size of treatment effect. So when they make recommendation, they classify them. So you can see the here the second column is class 1 recommendation, then they have class 2A recommendation, then they have class 2B recommendation, and then they have class 3 either no benefit or class 3 with harm recommendation. Now here's how they define it, and they color code the recommendation. So they say class 1 recommendation basically means that the benefit way outweighs the risk. So these recommendations should be performed or administered. Now again, this is not to replace clinical judgment. So every now and then, if you find a patient that the recommendation does not apply to, then you shouldn't really use it. But for the most part, class 1 recommendation should be performed or administered for most patients. Then they have class 2A recommendations, which basically means that the benefit outweighs the risk, but not as much as a class 1 recommendation. So it's reasonable to do class 2A recommendations. And then they have class 2B, which the benefit outweighs the risk, or at least the benefit is as the same as the risk, so the same amount of, so you gotta balance it. So you may consider it, but you have to make sure that you balance the benefit and risk in that specific patient. And then the last one is class 3 recommendation, and basically class 3 is what you should not do, and it could be for 2 reasons. So if it's a class 3 no benefit, you basically should not do it because there's no benefit, or you should not do it because it actually may cause more harm. So if the risk outweighs the benefit, it will be class 3 harm. So this is how they classify the recommendations. So that basically tells you about the size of the treatment effect or treatment effectiveness. And then for each of these, then you need to support it with evidence. So then on the y-axis, they tell you the estimate of certainty or precision of treatment effect. And that's where evidence comes in. So the level of evidence could be A, B, or C. And when they talk about level of evidence A, they basically means that multiple populations has been evaluated, and the data has been derived from multiple randomized clinical trial or meta-analysis. So if you remember the level of evidence, or I should say quality of evidence pyramid, these are relatively high on the pyramid. So when you have a recommendation that is the level of evidence is A, that means it's well supported with good quality evidence. I know, so a recommendation could be class 1A, or it could be 2A, level of evidence A, or class of recommendation 2B, level of evidence A, or it could even be class 3 with level of evidence A. So it doesn't matter what classification is, if you have good quality evidence for that recommendation, it will be level of evidence B. And then for any of them, you can also have level of evidence B, and that basically means that data derived from a single randomized trial or from non-randomized studies. And then we have level C evidence, which basically means consensus opinion of experts, or from case studies, or if it's just standard of care, this what we've been doing, even though there's no evidence. Now let's take a look at how we actually use this. So here I have the endocarditis guideline from American Heart Association that we found earlier. Now if you scroll down through this document, you know, of course, just like any article, it has a title, it has the authors that worked on this, and it has an abstract. So here's like a quick abstract of, basically like a summary of what this document is going to tell the readers. And then it has like an introduction section. And then it actually tells you about their method. So they tell you, here's the table that I just showed you. So they tell you how they evaluated the evidence, and then if you scroll down, then it has sections where it makes recommendations. So here's the first part. So this part is actually about diagnosis. So let me scroll back up so you can see. So here's the section for diagnosis of endocarditis stars. So here's the text of it. So they start talking about diagnosis of endocarditis, but if you scroll down, they make the actual recommendations nice and bold, so they summarize it. So they say here are the actual recommendations, which you will get from all that text. They actually tell you the evidence of how they came up with these recommendations. So you actually need to read the text to understand how they use the evidence to come up with these recommendations. And then if you're in a hurry to come up with the answer, here's the summary. So they tell you, here's the recommendation. So recommendation number 1, again, you guys have not learned endocarditis, so don't worry about what the recommendation actually is. I just want you to understand the format of this recommendation. So they make a recommendation. So here's a statement. At least 3 sets of blood cultures obtained from different venipuncture sites should be obtained. With the first and last sample drawn at least 1 hour apart. And then they tell you this is a class 1 recommendation, so that's the green column. And then they tell you the level of evidence A. So that's how you know that, well, this is a class 1 recommendation, so the benefit way outweighs the risk, and it's based on good quality evidence. The same is true with the second recommendation, and if you keep scroll down, actually they only had 2 recommendations. So let's go to another section. Okay, so here's the next section. So they only have 1 recommendation for the next section. So the next section is actually echocardiography. So for this, they only have 1 recommendation. And again, this happens to be a class 1 recommendation, but in this case, the level of evidence is B. So still, good quality evidence, but it's not as good as level 1. Now let's keep scrolling down, go to another section. So this is a good one. So here's a recommendation, and they tell you that, okay, so don't worry about, what TTE is. Just understand the format of this. They tell you that this recommendation, this statement that they just listed here, is a class 2A recommendation, and the level of evidence is C. So it's kind of like an expert opinion. So, that's how you would interpret. So, when you use a guideline and you use the recommendation, you should also pay attention to the class of recommendation and also level of evidence. Now, let's take a look at an example of a guideline from IDSA. So I'm going to search for pneumonia guideline. So if you just search PubMed for pneumonia, again, so if you just type pneumonia, note that it will give you 142,000 results. So use your filters to your advantage. So I'm going to add guideline. So if you look for guideline and you add guideline filter and then you select it, so now it's down to 322. I'm also interested in guidelines in English. So if you click on additional filter and choose language and click show, and then I choose English, and it's down to 229. And then I want the recent guideline. I'm going to choose in the past 5 years. So now it's down to 51. Now, let's see. I read the first one, which definitely has pneumonia in the title. Now, this happens to be the European guideline. So I'm interested in the guideline in the United States. So I'm going to skip this one. The next one that has pneumonia, this is a specific kind of pneumonia that I'm not looking for. This one is in children, so I want to see the one in adults. Nothing says pneumonia. This is again, this is not the pneumonia I'm looking for. This is a PCP. The same with these two. Um, Now this one, it says streamlining safety data collection. That's not what I'm looking for. And here's, so remember I said IDSA is the organization that makes the guideline. So now I see IDSA. So you see, so within the first page of my search results, I was able to find the guideline. So number 20 is, so I see the keyword IDSA. I know IDSA is the organization that makes the guideline. And it says, actually this is a cocci. So the problem with this one is it doesn't say pneumonia. So we gotta keep searching. So that was for cocci. And if you go to the next one, now it says pneumonia. It says pneumonia and it says IDSA, so Infectious Diseases Society of America. So this was actually item number 21. So if you click this, now I know this is management of adults with hospital-acquired and ventilator-associated pneumonia. This is a 2016 IDSA guideline. So which is nice. Now I went through PubMed through the Loma Linda University. So now you can see there are three icons here. So if I click on the Oxford, this will actually take me to the Clinical Infectious Diseases Journal. So Clinical Infectious Diseases Journal is the official journal for IDSA. Now this guideline is also available. The full text is available for free through PubMed Central. So if you wanted, you can also click on PubMed Central. And if you want to get it through Loma Linda University Library, you can actually click this icon. So I'm just going to click on the Oxford one to see if it's actually available for free through the journal. And it will take me to Clinical Infectious Diseases Journal, which is again IDSA's official journal. And it turns out this actually is available for free on the journal. So you see the free, and you can actually get the PDF of it. So if you click the PDF here, it shows you the PDF. Okay. So now I have the guideline open. Now let's navigate it. Again, this is like just like a normal article. So it has a title, it has the name of the authors, it has like a abstract summary, and then another thing that's important about this, they actually give you an executive summary. Executive summary basically means first they're just going to give you a summary of all of their recommendations, and then they give you the full text. So if I make this smaller, so you can see the executive summary has all the recommendations. So these are all recommendations, page after page of recommendation. So that's nice. If you're in a hurry, it has all the recommendations at the top of the document. But then you're interested at the actual evidence for all of this. So that's why you need to go past the executive summary. Now, so the executive summary ends here. And then now you see introduction. So from here on is the actual full text of the guideline, because that's where they're gonna summarize the evidence. So I'm just gonna, so if you keep scroll down, it gives you the methodology. So they tell you how they evaluated the evidence to come up with these recommendations. So they tell you that they actually use the PICO. So they say that they use PICO questions. So, and they tell you the P stands for patient population, the I stands for intervention, C for comparator or control, and O for outcome. So every question that they raised in this guideline, in order for them to make recommendations for, they use the PICO framework. And then they tell you that they did a review of the evidence. And if you keep reading on, then they developed recommendations. So they say that all recommendations were labeled as either strong or weak. So remember how American Heart Association uses class 1, class 2A, class 2B, and class 3. IDSA has a system where they just tell you if it's a strong recommendation or a weak recommendation. And then they use the grade approach to basically rate the evidence. Now let's take a look at an example. So if you scroll down, let's see. Let's go down to, okay. So here's section 1. So section 1, here's a question. So they use the PICO question. So should patients with suspected, and don't worry about what VAP or any of these means. You will learn about pneumonia next year. But basically they raised a clinical question. So this is a foreground question using the PICO format, and they made a recommendation. So they have actually made a recommendation. So here's a recommendation. So again, here's a statement that's a recommendation, and then they say, okay, this recommendation is a weak recommendation, and it has a low quality evidence. So remember I showed you earlier that grade system shows you like low, very low, moderate or strong recommendations, or I'm sorry, quality of evidence. So that's how they use it. So they tell you that they're using the grades framework to tell you about the quality of evidence. And they do that, and then so the format is that here's a PICO question, here's a recommendation for it, here's the rating of the recommendation for it, and then they give you a summary of the evidence. So they actually tell you, and they give you references that you can see from the end of, and they actually evaluate the evidence. So in order for you to actually understand this recommendation, you need to know you need to be familiar with the evidence and understand, analyze, and evaluate it, rather than just memorize this recommendation. And they do that for everything. So let's see the next one. So here's question number 2. So again, they ask another PICO question. Here's the recommendation, and they tell you that this is also a weak recommendation, and they have a very low quality evidence. And then up here, here's a summary of the evidence. So here's 2 examples of clinical practice guidelines. So American Heart Association and IDSA are 2 of the common ones. There are other ones that we will explore in class, but as long as you understand that you need to know what system the guidelines are using, any guideline that you encounter, you can easily just figure it out. You can figure out how they basically tell you how they classify their recommendations, and how do they evaluate the quality of evidence. And if they don't, then that tells you that that's not a very good guideline. Good guidelines, such as American Heart Association guidelines and IDSA guidelines, have the process for classifying the recommendations and telling you the quality of evidence. That concludes this presentation.